You're listening to the UBC Medicine Learning Network.
You're listening to Metamorphosis, a podcast designed to help medical students navigate their medical careers. Today's episode is another installment of our resident series, where we are interviewing residents with the aim of learning about their path to residency and the specialty they ended up pursuing. My name is Ali.
And my name is Adam. On today's episode, we'll be chatting with Dr. Armaan Malhotra, a PGY1 and soon-to-be PGY2 resident in neurosurgery at the University of Toronto. So thanks for joining us on the show today, Armaan.
Yeah, thanks for having me.
So we wanted to start off with kind of a question that we haven't really asked to many other people on the show, and that is, for the people that aren't in medicine and don't know what neurosurgeons do, what would you say they think neurosurgeons do on a day-to-day basis?
Yeah, I think that's a great question. I think, I didn't have the best answer to that until maybe I was midway through PGY1, even having done the majority of my fourth year in neurosurgery. I think, there's a perception that's certainly informed by the media about what neurosurgery is on a daily basis. And I think, there are some elements that very rarely are true, but I think the majority of the job is completely different as to what's advertised to the general public. It's a surgical specialty where you deal with a vast kind of range of structural pathologies involving the brain, spine, and peripheral nerves. Due to the importance of those structures, there are certainly moments where things are extremely acute and urgent, and intervention is absolutely required in a very timely fashion. But there are other times where we have times to get coffees and chat about our weekends and run clinics that are fairly calm and routine.
So it sounds like the media doesn't do a great job of portraying accurately what it is neurosurgeons do. Would you agree with that?
Yeah, I would say so. I think in general, if you look at the portrayal of most medical specialties, I think neurosurgery or any other specialty for that matter, I don't necessarily think it's portrayed the best. I mean, I personally love house, but I think to be an intern who can also do an appendectomy and then see a patient in the emerge and then make a diagnosis of, lupus.
Always lupus.
Yeah, exactly. I don't really know if that physician exists.
Right. Yeah. All right. And so taking you back to kind of the very start of medical school, was neurosurgery on your radar, or kind of where was your head at in terms of specialties?
So neurosurgery, I didn't actually know really that it existed, other than that perhaps a distant part that I'd seen in the media. I think coming into medical school, I was definitely overwhelmed by the breadth of specialty options and sort of the diversity of career paths that lay ahead. I think I remember just the first week of medical school, just getting used to meeting people, and you already had people in your class who were shadowing multiple things and coming back saying, I spent the day in the OR and saw this great case, and you suddenly think, I just got here, and suddenly I have to decide what I need to do. So I definitely did not know about neurosurgery early on, and actually found myself in work with global health and sickle cell disease, as well as pediatric plastic surgery in my first year.
What kind of things did you do with global health in your first year?
Yeah, so at UBC in Vancouver, there was a great opportunity to be involved in the Global Health Initiative, which is sort of an umbrella program that allowed junior medical students to get involved with projects that had been established that were in the arena of global health related work. And so sort of uniquely, we were coming in a year where the second year medical student had actually totally started a new initiative in Nepal, looking at screening and diagnostics for sickle cell disease and incidence in a rural part of Nepal. The interesting thing in that situation was the government actually had an entire infrastructure to provide patients who were diagnosed or screened positive with sickle cell disease, subsidized kind of healthcare access, access to vaccinations, and but there was a huge discrepancy because some of the most marginalized patients were the ones who had the highest risk of sickle cell disease, in particular in a western part of Nepal. So the goal of this project was to improve the screening infrastructure and diagnostics in that area, and then develop an education platform to try to connect those patients who screen positive with genetic counseling and with government services.
So is that something that you were able to be on the ground for?
Yeah. So we kind of spent the entire year planning a second phase project after an initial large screening camp was done the year before us. And this was the second year of this project. So, there were 8 of us, medical students, and we got to Kathmandu on the first day. And unfortunately, we're sort of stopped dead in our tracks by the bureaucracy that can kind of underlie healthcare deployment in some of these more challenged healthcare infrastructures. And so when we arrived, there was one key person who essentially at the last minute totally said that our project was not in line with what they had hoped it would be.
Oh wow.
And this was after getting approval from the Minister of Health, from multiple hematopathologists, and this particular administrator was totally unrelated to the medical field at all. They just needed to essentially give us a license to be able to do this in this particular area.
Right.
And so we certainly had to do some creative problem solving on the ground, but managed to come up with a pretty impactful project at the end of it.
Oh, that's awesome. I know that's something that's still running today. So glad that you kind of got that off the ground in the year that you did.
No, and definitely with a lot of help from our seniors that year who started the project.
Yeah. And was that something that you found coming back from the trip and from the whole project, that helped to inform kind of your personal interests in medicine, or kind of start to shape that a little bit?
Yeah, I think one of the things that it kind of one of the doors it opened was this issue about access to healthcare, and I think it's very attractive initially to think about those problems on the scale of countries and different very foreign environments. But I think one of the major takeaways was that underscoring a lot of work in global health is improving access to patients who don't have access to certain care. And so as my interest in neurosurgery sort of got sparked early in second year, with some of the lectures that were more focused on the nervous system, and some neurosurgeons who spent more time teaching us in the classroom, I ended up kind of merging those interests and working with one of the neurosurgeons in Vancouver on a project looking at access to deep brain stimulation across Canada. And that was a tremendous learning opportunity for sure.
Yeah, no kidding. Now for more junior medical students, what's a brief way that you would explain deep brain stimulation?
Yeah, deep brain stimulation. So I'd never heard of it until we had a lecture on Parkinson's disease. It's like a pacemaker for certain cells or populations of cells in the brain.
Cool.
So specifically, you can implant electrodes using stereotaxis, which is essentially a frame, or in some cases a non-frame based way of inserting an electrode in a highly accurate way using image guidance and integrating it with operative technology to allow placement of an electrode within millimeters of a deep brain structure. So if you imagine you drill a small hole in the skull, and then you're aiming for a cluster or a nucleus or a region, for example, the globus pallidus or one of these deep structures, that you don't want to be off by millimeters, let alone centimeters, which is very easy to do. And so one of the interesting things in deep brain stimulation is you actually can listen to the frequencies of cell signaling and communication on the trajectory of the electrode into that deep brain area. And so someone who's trained in functional neurosurgery can walk into an OR and based on the sound of the transducer in the room, will know which pocket of neurons that
That's
electrode is
fascinating.
in.
Wow.
And so, this is like obviously highly subspecialized neurosurgery, which I won't even pretend to know about. But one of the things we were looking at is that by virtue of the fact that this is such a subspecialized field of neurosurgery, one of the main indications for deep brain stimulation is for treatment of medically refractory Parkinson's disease. So patients who have tremors that are debilitating, that are on multiple medications and are having side effects from these medications.
Mm-hmm.
And so if you look at that population, that's actually a significant population of, elder patients and patients across the country, but you only have a handful of centers across the country that are offering this service. So our goal was to assess what is the actual access across the country. How does that access differ between rural and urban populations? Does that access differ across provinces? And we sort of tried to answer some of those higher level questions.
Mm-hmm. And so at the end of this project, or even at the beginning of this project, where was your head at in terms of neurosurgery in general? And at that point, were you committed to pursuing it as your specialty?
No. So at that point, I think my clinical interest was certainly piqued, and I really liked the nervous system, neuroanatomy. I like the approach to sort of the undifferentiated neurological patient, where you're trying to localize lesions based on your understanding of anatomy and their symptoms. But I will also say that, I was thoroughly enjoying learning about ECG interpretation, learning about all of the internal medicine type topics. And I really did not know, through second year, majority of third year, whether I was sort of on the neurosurgery side of things or the internal medicine side of things. So I was really just going through with an open mind, but trying to explore neurosurgery in an active way by getting involved in research.
Right. That's interesting you mentioned that, because I think what we've started to hear a little bit from a number of guests that we've had on the show, that for a lot of people, that first division is the medical versus surgical specialty, and for some that's super clear. But it's quite nice to kind of hear a different perspective from you, saying that like you were having internal and neurosurgery on your list right until the very end.
Yeah, I think one of the things I found was challenging is that, you go through the process of trying to make decisions about your career and your future in the first and second years of medical school, where the majority of your time is not actually being immersed in the specialties that you're thinking about, right? Like You're not on a surgical service in the OR every day. You're learning about the cerebral aspects of surgical care versus medical care versus lab-based or radiologic type practice. And one of the things is, I found in first and second year, everything's new, everything's interesting, and you don't really know what the experience of being in a specialty is like. And I think that really, one of the things I really liked was going through with a little bit of an open mind, but also trying to proactively make decisions, and then really go into third year where you get thrust onto the wards with sort of interest in multiple things, but also with a little bit of a timeline to try to make a decision fairly quickly.
Right.
So going into clerkship, interested in neurosurgery, interested in internal medicine, how did the track that you ended up in end up informing your decision in the end?
Yeah, so at UBC, I'm not sure if this is specified elsewhere in the podcast, but you have different tracks, and so in particular, the track I had in my third year core rotations was starting with surgery, and then followed by psychiatry and internal medicine.
Okay.
So within the first half of the year, I had exposure to the two things that I was seriously considering.
Mm-hmm.
And so at that time, I would have been hard pressed to say, I'm 100% committed to neurosurgery. I was also thinking about orthopedics for that avenue to spine, for example. I was thinking about ophthalmology. I was thinking about internal medicine, and within internal medicine, critical care, cardiology, infectious disease, all for different reasons. But neurosurgery, for the reason of the anatomy, the patient population, and some few shadowing experiences, was sort of highest on my list. So interestingly enough, my first rotation of clerkship was neurosurgery.
Oh, no way.
The first patient I ever admitted, quote unquote, like admitted under the close supervision of a resident, was a patient with a tectal tumor and presented with Paranode syndrome, which is a fairly classic neurological syndrome of up gaze palsy, convergent nystagmus, and sort of some typical findings, as well as hydrocephalus. And so this was a patient who, we admitted, they were GCS 15 awake, and over the course of that first call shift, within a couple hours, we had to take to the OR for an urgent EVD, and the staff actually, once the burr hole was drilled and, basically with the resident holding my hand, allowed me to kind of place the drain, and you kind of feel the reward of that CSF rushing out, and the patient doing better post-op. So that was a phenomenal experience. And I still think it was very lucky to have been in that situation as a brand new third-year medical student to the wards. But I'll remember that throughout my entire career as sort of one of the first times I was doing something in a neurosurgical OR.
Right. It's a heck of a first week.
Yeah, no
first
kidding.
rotation.
No
Yeah,
kidding.
exactly.
This is a bit of a naive question on my end, but so when you said like kind of quote unquote admitting a patient, what does that actually look like in neurosurge, just even when you were a clerk? So are you kind of walking through the hospital, like the neuro floor, and then also in the OR? What does that look like?
Yeah. So typically, on a surgical service, your the chief resident and the fellow will be in the operating room with the staff. There'll be a certain staff person who is on call, and depending on the hospital you're at, that staff person will field calls from outside of that hospital. So the staff person that day was taking calls from all over British Columbia.
Oh, okay.
This particular patient was coming from a northern part of BC, and there was a rural emergency physician who had done a CT scan and found this lesion, hydrocephalus, and was sending the patient down for assessment and intervention.
Okay.
And so this was a patient we were expecting, and was basically being air ambulanced into the hospital. And so once they arrive, the workflow is that the resident on call will get a page from the emergency triage and say, your patient's here. And this is the patient that you're expecting. That resident may also get calls from the emergency or any other service within the hospital that's consulting them. So as the resident, you typically have responsibility in the OR, as well as responsibility to all of the issues that are happening on call. So that particular day, when the patient came in, they were GCS 15 at triage, and they were kind of awake and bright and moving their arms and legs really well. And so the resident had asked me to basically go and see that patient and do my history and physical and come up with a quote unquote plan, right? So between third and fourth year, you're really trying to build your skills about asking pertinent history questions, pertinent past medical history, and then coming up with a cohesive story and trying to take steps into developing a plan for that patient. I think the plan formation is more of a fourth year and first year resident type skill. But the act of seeing a patient cohesively, kind of understanding why they're here and what's important to the specialty you're representing, and then communicating that to your team. If you can do that really well, you'll sail through clerkship.
Right.
That's sort of the core clerkship goal, is to know what's pertinent, do a focused exam, and then communicate that exam effectively.
And then, after you had completed these surgical experiences and moved on to psychiatry and internal, how did those experiences go? And were they just as good, or, did you have an experience that said, no, I actually preferred neurosurgery overall?
Yeah. So I think on psychiatry, I really enjoyed it. It was a very different side of the spectrum of neurological disease, but it was something that I didn't necessarily want to do, and kind of realized that fairly early. Mm-hmm. When I came to internal medicine and started on CTU, I had a string of staff people who were just amazing mentors, and it made the decision extremely challenging because
Right.
I came in fresh from this sort of high of being on surgery for 3 months, and then suddenly I found that I was really enjoying internal medicine. The teaching was excellent. I really liked the undifferentiated patient, but then also having the ability to make hypotheses and then test those hypotheses and then try to come up with an answer or a diagnosis, and that informs your treatment. But I think the group of residents as well as the staff person played a huge role in first of all teaching me how to be a good medical student, and then also teaching me about how much I could like internal medicine.
Okay. And one of the things that, as a result of your track system, you had kind of your top specialties right off the bat. And one recommendation that we've heard is to try and have your track so that your top specialties are last, so that you'll be the most experienced clerk going into them and can make a good impression. How did you find having your top specialties right off the bat compared to, if you had them later on?
Yeah, that's a great question. I mean, I think there's always at the end of the day that the tracks are lottery based, right? So I think the reality is that nothing that the lottery churns out will be so shaping of your future that you won't be able to sort of take a certain trajectory or career path. I think in my case, I was fortunate because I came in with some uncertainty about what I wanted to do, and really wanted to see what surgery was, see what internal medicine was, and then try to decide. So I really didn't have that much pressure on myself to try to show up that first day and know everything. Sure, I would read around cases and try to be a good medical student, but I had no idea where to even stand during rounds. Like, you get to the hospital and people are doing things. There's always the classic story of like following the resident, and then they end up going to the bathroom, and you're like, am I standing here? Right? Like, you know what I mean? It's so a lot of that was just learning how the hospital worked. And I think almost being in neurosurgery the first couple of weeks, it just took the pressure off of me. It took the pressure off of everyone there. They're like, oh, this is a fresh clerk. We're not going to, I think the expectation of a third year medical student is to be a good team-oriented person, have an aptitude to try to learn and pick things up. But, they're not going to be asking you for the differential diagnosis of, a pineal gland lesion when you show up on your first day.
Right.
That's the flip side. Yeah. The flip side to that is, I definitely have friends who knew with certainty that, I'm for sure doing ophthalmology, or I'm for sure going to be a family physician. And in that case, there is something to be said about doing that at the end of your whole entire year and trying to use that as time to get reference letters. The one thing I may caution is that anytime you have a reference letter from third year, I would say that there should be ample opportunity to get a reference letter in fourth year if it's in the same specialty that you're booking electives in fourth year.
Gotcha.
I can't speak to what committees look for, but intuitively it would make more sense. And I would suspect a fourth year rotation is a better representation of your skills just from a temporal standpoint than any third year rotation.
Definitely. And when it came to fourth year for you, because you mentioned you still hadn't really made that 100% decision between neurosurgeon and internal, is that how you structured your electives, kind of like trying to really make that call?
Yeah, exactly. So I think at the beginning of at the end of my third year, if you asked me, I would have said that, I'm leaning towards neurosurgery, but I'm still curious about internal medicine because I was only exposed to the CTU, and obviously in internal medicine, you have all of the subspecialties, and I wanted to see those things. I like the idea of critical care, of the procedural aspect of cardiology, of GI, for example, respirology. So the way I structured my fourth year was I did predominantly out of province neurosurgery. I started with 4 weeks of ICU because I thought that would be good exposure to internal medicine as well as neurosurgery. And I did ICU at Vancouver General Hospital, which, a lot of those patients are traumatic brain injury, subarachnoid hemorrhage, as well as medical ICU patients. So that was excellent, just sort of foundational training. And really, I wouldn't say that sort of pushed me in one direction or the other, but as soon as I started my rotations where I was consistently in the operating room on a neurosurgical service for, I ended up doing 10 weeks in a row. It was sort of like, I think I didn't really feel that convinced that this is the right thing for me on any other part of my medical training other than those 10 weeks.
And so then fast forwarding to the CARMS process, what was that like now, going for neurosurgery and obviously it being a competitive specialty?
Yeah. So I in hindsight, the CARMS tour was, two of the craziest, most fun weeks of medical school. I think I remember the stress of the first interview and the night before. Our first stop was Dalhousie. And, we were showing up in January. It was like -20. We landed the day before. It was dark. You have to take this like 45-minute shuttle from the airport to the Airbnb that you're staying. So I kind of walked into this Airbnb and there was this huge dog that was there, super cute dog. But the next morning when I was I had just put on my suit and I was ready to go, this dog basically ran out of one of the rooms and just like tackled me. And so I had all this fuzz all over my suit. I ended up switching to my second suit, which was a good call that I had two. And then definitely stayed at hotels from there on as opposed to Airbnbs. But the nice thing about the neurosurgery tour and a lot of these smaller tours is that you get to know a lot of your co-residents. And even to this date, the people I met on the CARMS tour and those 2 weeks, they're all our colleagues across the country. And so, you always hear of people doing certain things, and it's nice to kind of suddenly know every single PGY1 in neurosurgery in the country at any given time. Like I could almost tell you a story about each person, right? Like it was a really nice way to get to know everybody who's kind of moving into your career path.
So you ended up in Toronto. So how did you come to that decision?
The decision about Toronto. So I did my high school, medical school, undergrad studies all in Vancouver. When it came down to deciding, there are different factors that you have to consider. I think everybody it's a very personal decision and certainly tests, your value system and the place that you see yourself being happy training, the program and people that you want to be around during training, and the people and personal life that you also want to have and cultivate during training. So I think when I did my rotations in different parts of the country, I found that I'd be really happy with the groups of residents in most of the different stops along the tour. I thought that there were very solid groups of residents and colleagues. I really liked the city of Toronto. It was just kind of this huge city that, felt like it had a lot of, like I could really explore it from food, coffee, like everything the city had to offer. I really like outdoor sports. And so leaving Vancouver and what it had to offer was definitely challenging. But there was a tremendous amount of just wanting to jump into something totally new. And it felt like a nice time to just really try something that was, going to push me both outside of work and at work to just land in a new place and sort of start a new residency. In terms of Toronto specifically, a lot of the research that's done in Toronto with regard to neurosurgery was research that I was interested in getting involved in. Neurosurgery residency, your fourth year is mandatory entire calendar year of research. And so, so that's why it's a 6-year program. And so I was really looking forward to the opportunities that would be available in Toronto for that fourth year.
That's interesting. And so now, I guess, a full year into the program, how have those expectations of Toronto and University of Toronto's residency program, how have those lived up to the actual realities?
Yeah, so I think for any resident who is kind of moving from an area that they're very comfortable to a different city and a different program, there are definitely waves to that. And I found that the excitement of the first couple months of being in a new residency program, they were all great. And but I definitely remember around October of my first year, kind of thinking that like this is really sinking in, that this is home and this is where I'm going to be. And you're sort of keeping in touch with all of these great friends from medical school, and most of them are back home. And that was a very sort of delayed reality to sink in. But then you kind of realize that there are such great people here that you have the chance to work with, and I think I've really gotten to know a lot of people in the program really well, people in surgical foundations. So those are other first year residents, to the point where now Toronto is feeling more comfortable. It's feeling small. I was just on call yesterday. You bump into another first year. So I saw my friend in general surgery. We're both called to a trauma last night, and you just see that familiar face, and suddenly the whole city and the whole program feels a lot smaller. So it's nice when those things happen, and that just takes time, and it will happen for everyone. I think the program's definitely lived up. I have nothing but great things to say about my experience so far as a PGY1. I think I've been taught and mentored very well. I definitely feel overwhelmed by expectations in coming years, but I think that's very normal for anybody, any resident in any program.
Any medical student, really.
Yeah, pretty much at any point of the past like 9 years.
Yeah. Now, what does the program actually look like for like on a day-to-day basis for you?
Yeah, so every residency program is split into blocks. So each block roughly reflects 1 month on the calendar. And your first and second year, you tend to do more blocks or rotations that are maybe away or sort of related, but not completely related to your specialty of training. So for example, in my first year, I did a couple months of plastic surgery. I was scheduled for a month of general emergency medicine, but actually got redeployed away from that because of coronavirus sort of changes and coverage requirements. But then you also have the responsibility of becoming, a good junior resident at your home discipline and doing reading around that. And so a regular day, you kind of come into round between 5:30 and 6:30, depending on the service. What that means is you meet the team, and one member of that team was on call from the previous night. They will let you know about any consults or overnight issues for ward patients or new patients that came through the emergency. You then kind of, everybody has to get to the operating room by between 7:30 to 7:45. So from the time that you hand over to 7:30, you try to make your rounds and see all of your admitted patients.
Okay.
Make sure that everybody has plans for the day, speak to sort of the interdisciplinary health team, and sort of make sure that PT, OT, nursing, they all kind of have ideas of what the patient's disposition and plans are for the day. And then you go to the operating room. So, ideally you would have read about the case that you're doing. Typically as a junior resident, you would be, starting the case with the skin incision, doing the exposure. And as you get more comfortable, doing more and more portions of the case in a supervised fashion. And then at the end, you kind of hand over from the day anything that's gone on. The on-call person will have the pager, and so any issues will go through that person, and they will be the ones staying overnight until the next morning.
Awesome. And so we wanted to give you some space and some time to also speak about kind of what you see as part of your future practice. And now you've mentioned that, fourth year will be an opportunity to do some research, and obviously your background with the Nepal Sickle Cell Project. Where do you see kind of global surgery and advocacy work coming into your practice? And when do you think you'd like to pursue that?
Yeah, so that's a great question. That's sort of been the topic on my mind for the past year. And I still certainly don't have a cohesive answer that sort of is a trajectory for myself. I think, every month I kind of see myself doing different subspecialties within neurosurgery. Currently, I'm on my pediatrics rotation,
Oh,
and
cool.
really like the sort of breadth and applications to global health that are afforded by a career in pediatric neurosurgery. But in terms of exactly which subspecialty or research path I'll head in, I'm still not sure. At this point, I think it changes every month for me, and I think that sort of hopefully reflects that I chose the right general residency program, and I still have not got to the point where I'm completely set on a particular subspecialty within neurosurgery. I think there's still a lot of general neurosurgery that I need to be exposed to and see before picking that path. In terms of health advocacy and involvement in global health, I think one of the things that involvement in the sickle cell project sort of taught me was the balance between educational value and value that you can add to an initiative as somebody who is involved in an initiative. So I think, to elaborate on that, maybe historically, one of the models that was more applied in global surgery was this model of taking trained experts and then traveling or moving to a different area, doing a lot of surgeries, operating on a lot of patients who really have significant pathology that need attention, but perhaps not access to certain surgical services.
Okay.
But then those practitioners would leave, and they would sort of, those patients, they would still have complications or require subsequent management and sort of attention.
Right.
And so the sustainability of that model, even though it can have significant benefits, is certainly a criticism.
Right.
And so within the field of global surgery, there sort of was a pioneering paper in 2015 through the Lancet Commission on Global Surgery that sort of captured the burden of surgical disease in low and middle income countries and the real economic and social detriment to these gaps in access. And I think since that time, there's been a lot of exciting work done to try to make the world smaller through educational initiatives that can be, virtual, through fellowships that really allow for surgeons in certain parts of the world to train with other surgeons who maybe have had access to different educational means and methods, and then take those skills and go back to the area that they practice, and then be a longitudinal sort of person in that community, as opposed to just sort of helicoptering in and then leaving. So even in the neurosurgery community, there are certainly there's federations and groups of different neurosurgeons trying to do higher quality research, higher quality analysis of problems and how they're unique in certain low income settings, and sort of how to optimize solutions for those settings. I think so to kind of take that huge tangent and bring it back to myself, I often ask, like, when is the right time for me to actually, let's say, for example, you were to look at me going to a different part of the world and
Right.
being involved in neurosurgical care.
Mhm.
At this point, I would be a burden to whoever accepts me as on their neurosurgical, right? Like, I'm coming to the end of my first year of residency. I certainly don't have anything to offer. But I think when you look at collaboration, sort of in later years of training, there's a tremendous opportunity for that, and so I'm certainly excited to integrate that. But I don't fully know exactly how that will manifest. But I do have several mentors here at the Toronto Neurosurgery Program who are extremely involved in both virtual and in-person initiatives with different organizations and countries, where they're trying to cultivate neurosurgical access and programs. So certainly lots to learn from.
I think honestly, like, hearing your answer and saying the words "I'm not sure" and that you're still trying to figure it out, and that your mind changes on a month-to-month basis. I think that resonates with a lot of us, at least
Absolutely.
myself for sure. Especially with the way that our curriculums are designed. For you, you're changing blocks every month. For us, we're changing blocks every week now with the spiral curriculum. So we're definitely interested in every other thing that comes through the door. What would you say to first, second, third, even fourth year students who are trying to figure out what specialty they want to pursue? What kind of questions do you think they should ask themselves?
Yeah, so I mean, that's a great question. That's definitely the crux of a major stressor throughout all years of medical school is that looming decision. My sort of approach was sort of feeling overwhelmed for sure at first, and then just sort of realizing that there are a finite number of options. And so I think midway through first year, at some point, I just created a Word document with all of the possible specialties that were on the Royal College website, and there are only X number of specialties that you have the opportunity to go into. And so I sort of just listed them 1 to 30 or however many there were. And, I just sort of started getting rid of the ones that I maybe had some exposure to and it didn't completely resonate or click right away. And sure, I think if you immersed yourself in every specialty, you could always find something that you enjoy and love. But I think there's also a sort of a little bit of a gut feel that you have to be in tune with as you go through things. There are certain topics that you want to read more about. There are certain patients that are memorable, or certain experiences that you find yourself gravitating towards. So for me, in very broad terms, yes, it seemed paradoxical that I was interested in internal medicine and neurosurgery. But one of the things that I was really interested in was acute care and just sick patients. And I think that can be said about a lot of specialties, but I particularly found that, in the ICU, in cardiology, in GI, respirology, and in a lot of surgical specialties, you had really sick patients, particularly in neurosurgery and things like general surgery. And so I really like being involved in sort of the critical care meets the sort of surgical management of disease. And I just didn't know which side I wanted to be involved in. Right. And so as I got through the years, I sort of had a list that kind of came down to about 4 or 5 options by clerkship, and then down to 2 options by the beginning of fourth year. And I found that list actually really helped me sort of cognitively unburden myself from this perception of like an unending number of possibilities and needing to make the right choice. When actually, I know exactly how many choices I have in front of me, and I've had a systematic approach to kind of going through those. I think different things work for different people, and I'm definitely not saying that this should be everyone's approach, but it's one approach, and I felt like it worked well.
And I think that sentiment resonates a lot with me in terms of not necessarily putting things in the boxes of specialties and getting so hung up on, do I like internal or do I like family or do I like surgery, but thinking about what aspects of care, what aspects of medicine are particularly interesting to me. And I think that's something I'm going to kind of start using a little bit more going forward. So thanks for sharing that.
Totally. Yeah. I mean, next time you find yourself like, saying that, I want to do dermatology. Well, try to break it down. Like what about dermatology? There are going to be certain patient lifestyle and personal factors that go into every single time that you come up with that sort of thought that, and it's all about weighing those different things for yourself. And then, once you kind of actively reflect on those things, you'll just be more in tune with your own decision-making throughout those years, and it'll become less stressful, I think.
Right.
It's awesome.
Yeah. That last little sentiment there, that is something I hadn't thought of before. I get myself caught up in that all the time of like, I have shadowed honestly 3 times, twice. And they've both been in the internal kind of realm. And then I'm like, well, I need to go start shadowing other things. But then there's a little bit, like you said, of you're doing that for a reason too.
Exactly.
That's interesting.
Yeah. And you only see a very small subset of what there is to offer with each specialty when you shadow, right, on a given day. So even repeated shadowing in one thing that you're interested in is is also very beneficial.
Definitely. That's perfect. I think that is a perfect time and place to stop.
All right.
Guys.
And that brings us to the end of our episode. We want to make sure that Armaan is fully able to take advantage of his time off and do some of the things he normally doesn't get to, like getting some proper sleep. So thank you so much for joining us, Armaan.
Yeah, thanks so much.
And thanks for listening. For more episodes of Metamorphosis, you can look for us on Spotify, Apple Podcasts, or wherever you get your podcasts.
This episode was written, recorded, and edited with 100% adherence to social distancing guidelines. As usual, on behalf of the entire Metamorphosis team, we hope you are staying happy, healthy, and safe. See you next time, and remember to wash your hands.
Nice outro.
Thanks.
This has been a presentation of the UBC Medicine Learning Network.